All right, welcome back. In part one, we really dug into the what and the why of hypertensive disorders of pregnancy. Today, we get to the really critical stuff, the how. This is all about management. Think of this as your high-yield, practical guide for what to do when you're faced with these patients on your rotations and, of course, on your exams. Okay, let's jump right in.
So we're going to break this down into four main parts. First, the big one. When do we actually deliver the baby? Second, how do you handle a blood pressure that's through the roof? Third, we'll get into the details of magnesium sulfate for preventing seizures. And finally, we'll talk about the real life-threatening emergencies, eclampsia and HELP syndrome.
You know, the first and honestly the most important question we have to ask in managing preeclampsia is all about timing. See, delivery is the only real cure for this disease. But we're always walking this tightrope, balancing the risk to the mother against the risks of prematurity for the baby. So, how do you make that call?
Well, it pretty much boils down to these two key timelines. If you have a patient with preeclampsia without severe features, so just the high blood pressure and some protein in the urine, the goal is to get as close to term as possible. We call this expectant management, and we're aiming for delivery right at 37 weeks. But the moment severe features pop up, we're talking dangerously high blood pressures, signs the kidneys or liver are taking a hit, or crashing platelets, well, the clock speeds way up. At that point, delivery is indicated at 34 weeks. Now, here's the absolute rule that trumps everything else: instability. If the mother or the baby is crashing, I mean an eclamptic seizure, fluid in the lungs, uncontrollable blood pressures, you forget the timeline. You stabilize and you deliver immediately. End of story.
Okay, let's shift gears to our first acute scenario. You get that page, you run to the bedside, and your patient's blood pressure is sky high. This is a true obstetric emergency, and our number one goal here: prevent a maternal stroke.
So what's the magic number? It's this: a sustained systolic blood pressure of 160 or higher, or a diastolic of 110 or higher. The second you confirm that, an imaginary clock starts ticking. You have about 30 to 60 minutes to get that first dose of medication on board. This is not a let's wait and see situation. This is an act now situation, for sure.
And here are your go-to options. You've got three main tools in your toolbox. First up, IV Labetalol. It's a fantastic beta blocker, a real workhorse. But you have to remember, you can't use it in patients with asthma or a really low heart rate. Next is IV Hydralazine, a direct vasodilator. It also works great, but just be ready for some potential side effects, like a fast heart rate or a bad headache. And finally, what if you can't get an IV in quickly? Your answer is immediate release oral Nifedipine. Just remember the one cardinal rule: never, ever give it sublingually. You can get a massive, unpredictable drop in blood pressure, and that's incredibly dangerous.
All right, we've got the blood pressure coming down. Now we pivot to our next big priority: preventing seizures. And for that, the drug of choice, one of the most important medications in all of obstetrics, is magnesium sulfate.
So who gets it? The indication here is crystal clear. Every single patient who has preeclampsia with severe features gets magnesium sulfate to prevent seizures. That is the standard of care, period. Now, what about patients without severe features? You know, that's where it gets a little more controversial. ACOG says it should be a shared decision. For your exams and for the sickest patients you'll see, just burn this into your brain. Severe features equals magnesium.
So how do we actually give it? It's a really straightforward three-step protocol. First, you hit them with a loading dose, usually 4 to 6 grams IV, to get their levels up to a therapeutic range quickly. Think of it as front-loading the protection. Then you immediately start a continuous maintenance infusion, usually 1 to 2 grams an hour, to keep it there. And this is so important. We don't stop when the baby is out. The risk of a seizure is still really high in that first day postpartum, so we keep that infusion running for a full 24 hours after delivery.
Now, magnesium is an amazing drug, but it has a pretty narrow therapeutic window, so we have to watch for toxicity like a hawk. And what's great is that it follows a very predictable stepwise pattern. The very first sign that your levels are creeping up too high is the loss of deep tendon reflexes. You know, the patellar reflex. That is your canary in the coal mine. If the level keeps rising, the next thing you'll see is respiratory depression, and then in really extreme cases, cardiac arrest. This is exactly why you have to be doing frequent clinical checks.
So let's say you just checked. The reflexes are gone, and the patient's respiratory rate is starting to drop. What do? What's the one drug you absolutely need to have ready to go?
The answer is calcium gluconate. It works by directly fighting the effects of magnesium at the cellular level. So, If you even suspect magnesium toxicity, you stop the infusion and give a slow IV push of calcium gluconate. This is one of those things you just have to know.
Okay, now we're getting to the most feared complications of preeclampsia. These are the situations where acting fast and knowing your stuff can literally be the difference between life and death. We're talking about eclampsia and HELP syndrome.
First, let's make a really important distinction. Eclampsia is a clinical diagnosis. It's something you see. It's a seizure, specifically a new tonic-clonic seizure in a patient who has preeclampsia. HELP syndrome, on the other hand, is a laboratory diagnosis. It's an acronym that stands for hemolysis, elevated liver enzymes, and low platelets. So one's a seizure you witness, the other is a pattern you find in the laboratory results.
If your patient starts seizing, your priorities are simple and clear. First, the basics: airway, breathing, circulation. Protect their airway, make sure they're safe. The second and most critical step is to give magnesium sulfate. This is the definitive treatment. Your gut instinct might be to reach for a benzone like lorazepam, but don't. Magnesium is way better because it treats the underlying cause in the brain. Once the mother is stable, the final step is to move toward delivery. And for HELP syndrome, just remember, it's a very severe form of preeclampsia. The name itself tells you the diagnosis. H for hemolysis, which is where red blood cells are getting shredded. EL for elevated liver enzymes, which causes that classic right upper quadrant pain as the liver capsule stretches. And LP for low platelets. Just like with eclampsia, the ultimate treatment here is delivery.
So let's wrap this up. What are the absolute must-know points? Remember your delivery timelines. 37 weeks for non-severe, 34 weeks for severe. Treat any blood pressure over 160/110 right away to prevent a stroke. Use magnesium for every single severe case to prevent seizures. And always monitor for toxicity by checking those reflexes. And finally, when you're faced with the big emergencies, eclampsia or HELP, the answer is stabilize and deliver.
So, we've delivered the baby, we've delivered the placenta. That cures the disease, so the danger's over, right? Well, not so fast. We now understand that having preeclampsia is like a stress test for the cardiovascular system. It unmasks a future risk of high blood pressure, heart disease, and even stroke. So the conversation we have with these patients doesn't end at that 6-week postpartum visit. It's a conversation that really needs to last a lifetime.